Number one is a paper about rapid response teams. Any of you guys have these? Yeah. Okay. Are they rapid? Do they respond? So these are becoming.
Canadians over there? There you go. Are you from Toronto?
You look like a Toronto guy. Yeah. So the reason Rick is making that joke is because the province of Ontario basically put a lot of money into saying every hospital in the province will have one of these. And it was sort of a little bit ironic because it was one of these good ideas but hadn't really been tested. And at the time that they put all the money in and made this demand, the first big study came out which was very negative, said didn't do anything. What is the concept? The concept is in your hospital, there's outside of the ER, there's no doctor there for the most part. And so patients get sick. By the time anybody figures it out, if they call the doctor at home, the doctor takes a while to answer, or it says, oh, give him aspirin, or whatever it is. And nothing good happens. And by the time you do something, it's too late. So the thought was, let's have an in-house group that will get there earlier rather than later and do good things. And there are now a number of papers on this, which are fairly mixed in what they conclude. The biggest one still remains that we didn't find anything good, but there are a couple now which, at the other extreme, have found fabulous. It does everything great for everybody. And there are a few that say, well, it does seem to decrease the number of patients who actually arrest on the floor, but it just moves them to the ICU when they arrest there. So it's clearly a good concept. We shouldn't have the notion that you only get attention 8 to 5 on weekdays is a little bit crazy, but actually how you do this and what you accomplish with it probably varies a tremendous amount about the size of your hospital, where it is, et cetera. And, by the way, one last thing, which is that almost all hospitals which have reported about this, forget about, there are others that do it, but almost all the reports, this is being done mostly in non-teaching hospitals. Now it's being done in teaching hospitals as well, but the reports are in non-teaching hospitals. And in the teaching hospitals, they often involve a resident. In the non-teaching hospitals, community hospitals, they almost never involve a doctor. The doctor is on the team on call. But the team is actually a respiratory therapist, an ICU nurse, and maybe some mid-level provider in almost all of these. And the same is true, of course, in the teaching hospitals where, God forbid, it should be an attending who gets called.
But can I see your hands again about how many hospitals are doing this?
Does everybody know what we're talking about, what a rapid response team is? Because I'm not sure, I didn't really quite get it. It's just a group of, a predetermined group of people, sometimes with the doctor or not, that gets called for certain criteria for people on the floor who have increasing respiratory rates, vital sign changes, things just theoretically try to prevent them from arresting or resuscitate them on the floor so they don't deteriorate. That's the theory behind this. So, go ahead.
So our hospital is doing one of these things too. The problem is that those of you in the United States, there's this issue about protocols and whether in fact nurses can initiate protocols that involve any medications. They can order tests, but they can't really order drugs. You run into that. Your nurses can't give Tylenol in the emergency department for a febrile kid under a protocol anymore.
You have to order it.
Unless you have specifically ordered for that child to begin the febrile child protocol or something to that effect. And Joint Commission is doing this based on mandate from Medicare, CMS. Everybody's objecting to it. They say, we've been doing it for decades, and what are you talking about? But right now, it is a hot issue because it is CMS's mandate, and it's much more difficult to get Medicare to change their minds versus the Joint Commission.
But that's a separate issue from this. That's a bad enough issue as it is. But in terms of this, the notion is you get people who are dedicated to doing this. Almost all of these teams they get called if A, B, C, and D, or E is anybody thinks you want to call them. You feel free to call them. You're worried about the patient. The patient is worried. The patient can call. If you think about it, there's some things that are obviously good about the notion of having somebody be their rapid response before the catastrophe. On the other hand, it raises all sorts of questions about, does it actually work? Who's going to do it? How much resources do you have to put into this? Is it a good idea to have a nurse go there and start medicines on somebody who you called because you think they're having an emergency? Is that appropriate? which doctor is going to be willing to race in? You know, you have a hospitalist in your hospital. That's different. You know, you already have that there in place in some way. So you're just formalizing it. But what about if you don't? So I think this is, you know, it's an idea, but there are a lot of questions that I don't think anyone's answered. And certainly the papers have been far from uniformly positive.
Most of the people that we've had in these courses who've liked this have been the ER docs who used to get called to the floor to take care of these folks who don't get called up there anymore. And as far as I'm concerned, if that's what happens, have at it. Go let the hospitals do whatever they want to. Keep me in the ER. Because you know it's a mess when you go up to that person. I'd rather they call me up to a code where the person is dead and they stay dead and I can go back to work. Versus the code where you get them back and now we got stable and you're up there for 25 minutes and the ER goes to hell in a handbasket while you know, you're up there doing something. So this is actually fine for us if it helps you keep you down in the emergency department.
So our hospital is struggling with this because our doctors we're a one doctor place. It's you know, 170, 80 bed place, and they can go to the floor for a rest that, God forbid, they live, and then it's 45 minutes trying about what's right now, what's the problem, calling the doctor, et cetera, et cetera. The ER shuts down. So we're trying to get the OB anesthesiologist to get off their butt and be in the pool of helpers in terms of this as well. But anyway, this is taken off. This concept is, you know, last 2 years, a lot of papers on this now.
Any of you, any comments you want to make? Anybody feel strongly about this one way or the other?
Yeah, I feel strong. We run the airway for our place upstairs, big hospital. And it seems to me that we're asking for lots of evidence on this, but if you just sort of do the Einsteinian mind experiment, this makes sense. We have to work out the detail of it, but surely it is better than what happens in most places now, which is you just get really, really sick and then you crump and die, versus pulling out earlier and having a group come and assess you and make a decision. Even for our place where we're supposed to just get called for when you need an airway, it's already had the creep to they're really sick, and I can't tell you how many times the residents get up there, R4s go up there, sometimes with an attending, sometimes without, and just doing simple things like, did you try BiPAP? And they don't need to get intubated. Did you try a little nitrate for that pulmonary edema that the people upstairs just aren't used to thinking about?
Sure, but
I think it makes sense.
Well, yeah, but a lot of things that make sense don't work.
Right.
And in addition, there's a question of resources. Who's going to do it? And it's very different. Thinking about this conceptually, what makes sense in LA County Hospital and what makes sense in a small community hospital and what makes sense in a medium-sized hospital, they're all different.
Yep.
And so, you know, of course, having people who can respond quickly is a good idea, but how do you actually do that? That's not so simple to me, in my mind.
Well, now that we got that straightened out, go ahead, doctor.
Yes. But you look at this paper, for example, it points out that they did a really good job in decreasing the number of codes outside the ICU. But what's sort of fascinating is that they didn't report how many codes were in the hospital overall or how many people died. Now, it's hard for me to imagine that they counted the codes outside of the ICU but didn't count the codes inside or didn't count mortality. And since they didn't report it, my guess is that they just moved them into the ICU where they had their code.
Although the more recent papers, prior to, that have come out since then, some of them are showing a clear-cut decrease in their codes.
This can't be a question of it doesn't work. It has to work. I mean, it has to work because otherwise you're saying when somebody is getting sick, having a physician there doesn't work. We've never proven that works. And it may be that the entire specialty of medicine is BS. But the question is, and you could make a very good strong argument for that, because everybody still dies and we haven't fixed that. The question is about resource utilization. The question, and some people have said, why do we have so many stupid little community hospitals where there are no physicians on? Why don't we do it properly and have bigger hospitals where there are resources?
Where people wait 18 hours in your emergency room.
No, do it properly. Why don't we manage the healthcare system properly from top to bottom?
So you know, the reason it might not work is because maybe in theory it's a really good idea that you call early and people rush there and they're smart and they know what they're doing. But it turns out that your team doesn't have a doctor on it because nobody wants to pay the doctor, and it mostly doesn't get called early anyway. It waits till it's later, and the response isn't as rapid as there are a lot of reasons why, if you had adequate resources, it might work. But just because you say we're going to have a rapid response team doesn't mean it's going to work.
Yeah, well, I guess we're just arguing about different things. Do it properly, and do it properly. Don't throw up the straw man of a rapid response team as the respiratory therapist. That's not a rapid response team.
But that's what every rapid response team is. And
No,
No,
it's not.
this one has an intensivist.
You know, in Melbourne, where most of this started, the Austin Hospital, they have a group of people who know what they're doing go.
okay.
But the question is, are antibiotics necessary after incision and drainage of
And you know what?
cutaneous abscesses here?
Who cares about abstract number one anyway, really?
This is all new provocative stuff.
Abstract 2 is good.
IND.
So this is a review from UPenn of lots of different papers that says, you know, it used to be the treatment for an abscess was to IND it and drain the badness and no antibiotics, and most of those people got better. But then MRSA came along. Has that changed anything? MRSA bad, and you can get multiple abscesses, and it's really a fascinating disease which has developed in the last 5 years. And the answer, the summary of this is, the treatment for an abscess is still to IND and get the badness out, and you don't need antibiotics. So that's good news. But MRSA clearly is different. MRSA, community-acquired MRSA is clearly, empirically at our place and most places now, it's people come in not with one abscess but with multiple abscesses. They come back multiple times. But still the treatment for each individual abscess, unless they're febrile, unless they're immune suppressed, unless there's cellulitis way outside that abscess, remains the same. The question is how we stop them getting recurrent abscesses. Should we decolonize and all this stuff that we really don't know what to do with?
In any of these studies, did they look at the anatomical location of that uncomplicated abscess? Perineal versus non-perineal.
Not in these papers, and I've had an MRSA abscess intranasal. And I can tell you that the treatment for that was lots of antibiotics and IND, because the next place that this thing goes is into my cavernous sinus and then into my brain. So I think it's true with all abscesses, though you have to be careful about where they are.
I'll tell you the problem with this paper, though, is it's a lumped together 5 studies, 2 of which were in the pre-MRSA era. And I'm not sure that that is even remotely related to what we're seeing now. I'd like to see this paper redone with the post-MRSA approach. Don't lump together pre-MRSA, because it's a whole different ballgame now with MRSA out there.
There are actually several large state papers, including a couple that have just come out recently, which say that we treated MRSA and we treated abscesses with antibiotics or without antibiotics, but it turned out that since we didn't know it was MRSA, and it turned out we treated it with Keflex was the antibiotic, even though after the fact we figured out that 90% of them were MRSA, and guess what? Everybody got better in both groups, the antibiotic group, the not antibiotic group. I believe that MRSA is different in some ways, but that it remains true, that the treatment of local infection is drainage, and if you can get adequate drainage, it's good. And by the way, the papers that I just mentioned about included people who had a fever, included people who had surrounding cellulitis. They didn't include immunosuppressed, they didn't include high-risk areas like the perineum or the face. And maybe this will change, but so far there is already a fair amount of evidence that if you can drain it, it's going to do fine.
Would this panel agree, though, that in an unripe abscess where bedside ultrasound doesn't show a pus pocket yet,
Absolutely.
that you would give antibiotics and have them come back in a day or two, and then, if there's a pus pocket, drain it?
Absolutely. And, the other thing is that 75% of antibiotics in the United States are used for simple upper respiratory infections. You want to stop the terrible overuse of antibiotics. We should stop giving them for a cold, for quote bronchitis. If there's any question in your mind, it's no big deal to give these people antibiotics. If you're worried, give them the antibiotics. This is not going to break us. On the other hand, you should know that for the most part, it seems as though it's really becoming clear, I think, that if all they have is an abscess and you feel like you've drained it well, it's not incumbent upon you to do it.
So what antibiotic are we picking now?
Bactrim and Keflex.
Both and both?
Doxy. Doxy's a great
Well, that's like a belt and suspenders too, right? Bactrim and Keflex, so we'll catch either one, kind of thing.
Because we still have a lot of strep, so you
Quinda.
need to give the
Rifampin.
One
Flinda's
couple things
gone.
I think that this is a
Flinda's
much
gone.
more diverse disease, then it's not like it's an all or none. There may be a solitary or two abscesses. First event can be treated one way, but I'm seeing the recurrent ones, I'm seeing the huge ones, I'm seeing the complications like neck fash at our institution. So I think this is broader than just, oh, it's community-acquired MRSA skin infections. It's actually a much broader deal. And it's progressing faster than we can do true research to know what's right. So part of this is that you won't get a single answer from any panel of people because we all have different experiences and this thing is evolving quickly. So I think that's part of the problem with trying to take flat out all abscesses should just be IND to not get treated with antibiotics because they're not all the same. Is a big one different from a small one? Is the second abscess different from the first one? A recurrent different? We don't know. And I know that we're seeing a boatload of this disease in the county system, remarkable amount. One other thing I just want to mention, rifampin is used mainly to decrease the carriage rate in the nose. It's one of the only antibiotics out there that will basically decrease the efficacy of oral contraceptive pills. So please remember to tell people, women you give who are taking birth control pills that you give rifampin to use barrier protection. They can very well, it just inactivates the pill. It's one of the few that has that interaction. And since we don't usually use it, most of us don't think about it. But if you start prescribing it, please just add a little thing in your head that says, ooh, rifampin, I need to ask about oral contraceptives.
And Greg Moran says we should use it not singly, you use it with something else
Right.
because resistance is very quick. It's for this trying to reduce colonization, which is the huge issue.
Yeah. That's a good question. I don't know. I'm not sure, actually. So I would probably just recommend barrier protection just to be safe.
Two questions. The first one is with regard to packing the abscess. Is there any evidence to show one way or another that packing it will...
You mean where you put the rags in? The rags actually are like a cargo net for the bacteria and white cells to crawl out of there kind of thing, you know?
The only evidence about packing that I'm familiar with is for post-surgical infection drains for abdominal surgery, which clearly shows that packing increases the infection rate. And while this has been done for years widely for all sorts of abscesses, you pack it. I have never seen an article which says that that's useful or necessary. I don't think it's any different with MRSA. I don't think you need to pack it. The only thing you don't want it to do is close over and get a new abscess. Right. So, and that happens only in the first 24 hours if it's going to happen at all. So I think it's perfectly reasonable to put something in to keep it open for a short period of time. And I don't think there's any reason why you need to pack it.
And God forbid anybody comes back for a repacking. I mean, that is nuts. And unfortunately, your colleague sent them back to you and told the patient, they'll need to be repacked in a couple of days. You talk about a painful process, forget it. It's basically to keep the hole open for a couple of days.
Just
that's
take it out and tell them to
And this doctor made a good point about ultrasound to determine whether you have fluxions, because if it's not obviously going to be draining like Vesuvius, then how many of you, and I have done this as well, you IND it, and there's just nothing. And then, damn, it wasn't ready, I thought it was, who knows, kind of thing. And now with the ultrasound, you can determine whether there's some kind of collection there which you're going to get some yield out of.
Has anybody done a study on the difference between bedside ultrasound and needle aspiration before doing IND to determine?
I haven't seen that study.
There's one going on at county now. They've just started
Comparing those two?
comparing
But,
ultrasound, stick the needle in.
Right.
What's the gold standard, though? Open them all up, so they're having some issues with the methodology.
Yeah, but I think that we probably won't. They'll never really be done the way we would like, and it seems really clear that you can do bedside ultrasound. Really tells you. So I don't think we need to hurt the patient. Just do the bed. I think it makes a lot of sense. Just do the bedside ultrasound.
I had one that was missed with bedside ultrasound. That's why I asked.
Really?
So it comes back so you put them on antibiotics, and it comes back the next day, and it's. I mean, how do you know it was missed?
Well, because the patient had a negative ultrasound done by the radiology department, and this was perianal, 8 months pregnant, and 2 days later had an IND, and there was 10 cc's of blood.
Yeah, but they've done that. It's actually a
2 days later.
characteristic of the bug to cause necrosis. So it's one of the characteristics of this
It wasn't
community-acquired.
MRSA.
It was not MRSA?
Not
Because
But-
MRSA can do that pretty quickly.
But 2 days later, I mean, it's hard
Right.
to know for
The
sure.
other thing to know about this bug, that we just had 2 cases in the last week, so I wanted to mention this, and it was reported at our institution. This bug can cause neck fash, but not in a way that you remember neck fash, or that you were taught about neck fash. You're taught about neck fash as this just incredibly rapidly progressive, people get toxic, they go down the tubes in a matter of hours in front of your eyes. Community-acquired MRSA neck fash is different. What it tends to present as is a progressive, not rapidly, but definitely progressive cellulitis over a matter of several days that is just not responding to antibiotics. And it just gets worse and worse. And there is pain, but not quite as much pain out of proportion as you think of with neck fash. It's not necessarily skip lesions. It's just, why isn't this going away? We had 2 cases this week where when they opened them up, there was basically just necrotic tissue underneath. One of them, we got an ultrasound. So just basically this whole huge, long, linear fluid collection along this guy's leg. Just know that this is going to occur. So if you're seeing somebody who's been seen by their PMD twice, placed on antibiotics, and they come to you finally saying, it is just not going away. They don't look toxic necessarily, but they have neck fash.
Do they shoot?
Pardon?
Do they ID drug?
No, both are totally walking, talking, working, straight normal people without any risk factors at all.
And this is what Diane talked about before. We've had exactly the same thing. Because we work at county hospitals, have a huge number of jail patients and IV druggies. We have the same thing. We call it the slow neck fash. There's the MRSA, and it slowly just eats you away, whereas old neck fash, you have lots of endotoxins, and it would kill you systemically before it killed you from eating you away. It's really interesting, this stuff. And you've multiple areas of neck fash. So you've got an abscess here that's started to eat you away and one over here. And all these things aren't described because we're describing this as we go. It's like happening all the time. The other thing that's interesting to me clinically is cellulitis. So has cellulitis also changed? Every abscess now, 75% or more, according to Greg Moran and Dave Talon doing their IDNet, is MRSA. They're all MRSA now, pretty much. Is cellulitis all MRSA? And we don't know yet, although it appears that maybe 5 or 10% are on the rare cases where they actually inject and suck back stuff. So should we change the way we treat cellulitis? Most people say not yet. If it's just cellulitis without pus, probably treat it as strep, mostly in old staff, but I bet you that'll change in 5 years or less.
What about the possibility of, you were talking about decolonization,
Mm-hmm.
and is that like, you just send them to an ID guy or dunk them in Hibiclines?
Yeah, there's a whole thing but they don't know if it works. So you've had multiple, you scratch yourself, you get an abscess. You scratch yourself somewhere else, you get an abscess. So you've had multiple episodes. You'd put mupirocin in the nose, you clean everything, and you dunk them in alcohol, and you wash all their clothes to try and decolonize them. Some people said it works, some people said have had no success with that, and they just keep getting it.
So we're still not culturing abscesses.
Well, actually, there was LA County just required that all abscesses positive for MRSA be reported as a reportable disease now. They're trying to kind of get some surveillance on this. And so this idea of not culturing abscesses in the, that went away. I mean, there was no necessity to culture abscesses. You would drain them and they would go away 99% without anything else. But now there's these epidemiologic reasons that people want you to do this more so than before. What are the bugs that this is susceptible to, et cetera, et cetera. So I just saw this. This is just came out in I think maybe it's the state of California. It's actually it's not LA County.
I honestly don't see the point anymore because they're all MRSA. And Dave Talon and Greg Moran just got an $11 million grant to do proper surveillance where they actually do it prospectively. The surveillance you and I do is just every now and then when we remember. So the surveillance that they're doing, even in the last 2 years, has shown that it's taken off. Even in Kansas, which had no MRSA, now has MRSA. Montana had none, now they have it. And you can actually follow the genetic strains and follow it going all around the country.
Yep. The last thing to just be aware of, too, is that, and the CDC's following this, is that community-acquired MRSA, pneumonia after influenza-like illness, is a deadly disease. We all know that influenza, when it gets that person gets infected with Staph aureus, we've known about this for decades, they get a serious pneumonia. Problem is that now that they community-acquired MRSA as that Staph aureus strain, it tends to cause a fulminant, really, particularly in children. The 14 deaths that were reported this year in kids after influenza that then got community-acquired MRSA pneumonia, and they come in sick as a dog, highly toxic, very febrile, have true necrotizing pneumonia, and it's highly fatal.
I had an 18-year-old boy come in early in the morning with what looked like the flu, positive influenza A, got sent home. Came back 24 hours later, opacified both lungs, respiratory failure, despite intubation, rapid transport, and Vanco IV, died.
Yeah, we've had 3 this year, and all under 25.
One of the docs at the hospital just down the street from me died a couple of weeks ago. Same thing. little viral syndrome, then came in sepsis, grew out MRSA, dead within 24 hours.
And I've never seen an 18-year-old sucked away and killed by an infectious disease in my career.
Well, that's depressing.
It's good times.
Let's
do
talk
three.
about a much more exciting topic. Electronic medical records. How many of you think whoever invented them should go back to that circle of hell we talked about yesterday, where the lawyers and the bad paper people are? This paper looks at the idea of, does an electronic medical record improve quality indicators? The theory of having an electronic medical record would be that you have a place where everything can get collected, all those indicators of quality that we're all being measured by, you would improve upon. We could actually bill better, which is probably the biggest push toward the electronic medical record. Does it help us improve quality indicators? Getting aspirin to the people who need them, getting the antibiotics in on time. Does the electronic medical record help? No. It actually was better in only 2 of 17, worse on 1, and the rest was just a wash. And it's so painful to transition over to an electronic medical record. We've all been there. I'll let you guys tell your stories. But the bottom line is it's being pushed hugely. Google's going to probably get its next $1 billion from electronic health record business, that Yahoo and everybody else out there. But this is it's a huge push. It's actually a federal push to get to the electronic medical record so that we have electronic access to people's health care issues, et cetera. But this paper says it doesn't, as far as health quality indicators, it doesn't seem to help a lot in that regard.
Anybody want to whine about their electronic medical record?
Here's your forum. Bitch and moan.
It seems to be dichotomous that there are those people that love their records and the other group of people that absolutely
All right, let's see the
hate
hands
them.
of the people who love their records.
Electronic
I rest my case. Nobody loves their records.
The guys at Cedar
some-
Summit love this.
They like computer order entry. They like computer order entry where you can push this button and it blows out 40 tests for your abdominal pain. And you push that button and it blows out 30 tests for your chest pain, which is basically this huge over-ordering. Let's do the workup of abdominal pain, which is what we get paid to do in terms of deciding what needs to be done in a graded manner. But this is, so nobody's arguing about computer order entry. They like it for that reason. I think that's the wrong reason to like it. But this is generating a history, physical, progress notes, those kinds of things.
Isn't it like everything else where it's not one size fits all, that there are things that...
You like your electronic medical record at UCLA?
I hate mine.
There you go.
But there are people who do like it for better reasons than the one you say. At Kaiser, it works very well. You can learn lots of things in a nanosecond that you can't learn at other places.
Well,
and there are actually 4 systems in the United States which are different than everybody else in that they developed their own. They didn't buy a commercial one. They had local buy-in to all the things they did. They were flexible and made changes. And these systems actually work. And if you think about it, of course, having a computer makes sense.
Rapid response teams.
For some things. But it also causes problems sometimes. And if you just sort of impose on people some commercial system, it usually doesn't work well. Most medical records don't work very well, and it creates all sorts of problems that were unanticipated, etc. But that doesn't mean that the idea itself, if done right, just like any of these things, couldn't be useful.
Sound like rapid response
Rick,
teams
you
to
have
me.
a conflict of interest here, though, because you have a medical record
No, I don't.
scanning thing.
No, I'm a believer that we have data. We have really good data at our hospital. We have a community hospital, and we have a database where after the fact, after the patient's gone home, all of this data is entered into a database. And I can tell you every drug, every test, every supply, every key time by doctor, door-to-doctor times since 19...
But that's a type of medical
No, it isn't.
electronic
It
medical
isn't.
record.
It's
Sure it is.
it's a
Not just do
database.
it.
The issue here is that they have the most expensive people in the building being the data enterers. In our version of this is done after the fact in a quiet room where all of this stuff is scraped off and charges are generated, etc. They want doctors to be sitting in front of a computer being the data entry people, which is the fundamental mistake. It's not about data. It's about how you get the data.
Back in the back.
I guess I should preface it by saying yes. When we went to like a EMR-based system, it was painful. And putting in the information, it took a lot of time. People typing with 2 fingers and everything shut down. But I really found that it really helps with patient care afterward when you actually have all this data. You have literally you could sit there. Patient comes in front of the computer, see their old EKG, know that they've already been stressed, know what their cath, before you had to get a patient chart of 1,000 sheets of paper and try to flip through these things, which was ridiculous. It does seem to make,
There are
the process. You can almost work up a patient by sitting in front of the computer, knowing that they've already had all these things done.
It sounds like what you're complaining about, Rick, is that the doctor shouldn't be a secretary. I think we can all agree on that. But saying that it's not an electronic medical record if you do it in a different way is I think that's not exactly correct.
Well, the idea of taking operative reports, those are word perfect Word documents, and they basically put them into these systems where you can look up the operative reports, you can look up the stress test results, you can scan the EKG, and that's an EMR. That's the electrification of paper. But that's not the same thing as a history and physical done with pull-down menu, pull-down menu, pull-down menu. That's a totally different beast.
Actually, there's a gentleman with a striped shirt. You raise your hand up as well, along the wall.
Where's that?
No? Okay. Yep.
Our hospital's trying to get that to work with the scribes that follow doctors around with those towels and the portable computers, and then the doctor just does their physical exam out loud and says the orders as they're examining them, and then at the end the doctor just has to review.
So that's the integration of another soul in there to have them integrate.
They're using local medical students, or are you doing it for?
It's a great idea.
Kind of hours they need.
So they put those people as a buffer between the doctors and the computer system at $15 or $20 an hour. Turns out to be very expensive.
Most of them are free. They're local medical students who are trying to get
Our scribes, we have scribes that get $18 an hour. $18 an hour. And two of our scribes
I think it's a great idea.
are doctors. Two of our scribes are doctors from who are unlicensed in this country for waiting for their, whatever they call that thing where you get. Yeah, right. So they went to some third world place, and they're waiting to come into the country. And so some of these doctors are, hey, you missed it. They can help the doctors in many ways. Like Van was a doctor, and Grace is a doctor. The other Grace.
Is it good? Does Scribes work? Because it sounds to me fantastic.
It's variable. One of our doctors, if the scribe doesn't show up, will go nuts. He'll be sucking his thumb, rocking in the fetal position in the corner, and other doctors don't care that much about it.
I think part of the problem is that to administrators and people like that, the EMR is getting online, looking at somebody's EKG. But for someone practicing, the problem is getting the information into the computer. And that's where the problem is. We've been working on this for 10 years or longer, trying to find a way to do that. And there isn't anything I'm aware of that works in an emergency setting.
Well, except for a scribe. I mean, I think that's a phenomenally terrific idea.
Like most community hospitals, because we don't have people with that much medical
Well,
knowledge.
that's just it.
Spell the word.
We're going to talk about this more tomorrow, and we probably ought to save that. That's part of the Carl sheet about things that you've done to make your hospital better, faster, better, those kinds of things. We can talk about scribes tomorrow and about who the ideal people are to be scribes. It's not medical students. But anyway, let's move on.
You want to say something too?
Well, just quickly, I work with different systems, and the current system that I'm working with it's actually great. It gives you're able to create your own language.
Right.
So you create your own code, and then you could tie up with a whole paragraph of whatever you want. And so it
Macros.
depends on the user, and now I have a system where it's just so much easier to enter my history and physical using my language that I created.
And wait till pretty soon.
Back to my old dictation.
And pretty soon, this is going to be. You're going to have computer voice recognition stuff where you can make it. It'll be very easy to do that.
I mean, it's just faster, more efficient.
I think part of this, for the people that are frustrated, is it is when it's forced upon you, and you're supposed to walk into that shift that day and do it, is ridiculous. And if you're going to make this big of a transition, it should be something done offline, mastered offline, before you ever go online with it. And the biggest problem is it literally gets dropped right on top of you, and you go from Tuesday leaving it paper, coming back Wednesday with a computer, and the place shuts down.
And in fact, that's exactly right. And there was a big paper in the Annals of Internal Medicine which again pointed out that the 4 places where this works were all developed locally, they were all flexible, they all made many changes, and they all took several years before they got implemented, as opposed to most of us who had somebody come, bought a system, sorry, we can't change it, we've already spent $2 million, and you're stuck with it. Those are the ones that are horrible.
I just ask, does anybody use the Kurzweil system? I always see that at ASEP, voice recognition, macros, neuronormal, boom, up comes 2 paragraphs of a perfect exam you didn't you didn't do.
The record larger than life. All right, let's move on here now that we solved that problem. We can skip through number 4 because this is this is more of what we're going to talk about tomorrow in terms of our addiction to pediatric antibiotics. This compares Canada and Denmark, showing that the Canadians are giving this stuff out like water and that people in Denmark are not, and the Canadians are giving out expensive antibiotics and the people in Denmark are not.
And the Canadians are much less expensive and less antibiotics than the Americans, who are not included in here. So before we take too much
let's go after the Canadians. Come on. There's a whole road of America. You're giving this stuff out like water.
All the studies of comparing American and Canadian show that for all of these types of things, they are much more rational.
Talk about Article 7, I like that.
Yeah, we'll come to that one. We'll give you a pat on the back.
Exactly.
We're skipping that one. We're skipping that, baby.
Number 5 is a strange article which suggests that when they implemented a pay-per-performance in this with regard to heart disease, it didn't have any effect. It's strange because there's lots of evidence that if you want to change doctor behavior, there's only 2 ways to do it. One is to reward them, and the other is to punish them. And the rewards and punishments don't have to be money, but money is one of the strongest rewards and punishments. There's lots of literature that says when you reward or punish with things like money, incentives, you get big changes. And the biggest study of pay-per-performance was a big study in England where they made a real incentive for family practitioners to meet certain process goals, and my God, everything changed. They met them because their income depended on it. So this is a not particularly well done review of a database where they said, gee, in the hospitals where they had the pay-per-performance, it didn't work. And again, I think that's probably at best an outlier. It's probably not true. My problems with pay-per-performance have nothing to do with that it doesn't work. I think it does work, of course. If you're only going to get paid if you do something, you're going to do it. My problem is who gets to write the standards. We already know that with guidelines, they disagree with each other. They're often wrong. They don't take into account new information. They are biased. They're written by people who have conflicts of interest money-wise, and that they don't take into account that the patient doesn't have only one disease. The patient has 9 diseases. And so there was a great paper which looked at guidelines from the biggest organizations for very common chronic diseases like diabetes, hypertension, hyperlipidemia, and somebody put them all together, and they were full of things that were inconsistent between them, as though the patient can't have diabetes if the patient has hypertension. And not only that, but the best news was they said that for the average family physician, primary care physician, to actually take care of an average 70-year-old woman who had 5 comorbidities, which is an underestimate of the average 70-year-old woman in practice, would take 40 hours a week just to do guidelines, to do nothing else, to just follow the guidelines. So there's a lot of problems. This is one of these things where guidelines have some good things about them. Pay-per-performance guidelines could be done well and could have some good things about them, but the devil's in the detail. And so yet one more example of something where you just sort of impose it on us, there could be real problems.
Well, you know, this is it was intended to be one of those not-so-fast Ollie papers where pay-per-performance basically was not able to be demonstrated to result in any outcome measures, because what we're measuring really is process measures like antibiotics within 4 hours. Well, you know, is it 4 hours or is it, now they changed it, now it's 6 hours. It's okay now. So all of those people,
this is all process as well.
So these are process measures, and these are process measures as well. As an example, in the congestive heart failure thing, every time that you come into the hospital, they want to know that you have had some measure of your left ventricular function done. I'm not so sure that there's any literature that says well, if your function is this is the treatment you should get, and the function is that is the treatment you should get. Another one is smoking cessation for pneumonia patients. You're supposed to talk to them about smoking cessation. As soon as you talk to them, you've met the guideline. Outcome, we have no idea whether any of those people stop smoking or curtail their smoking one whit. So it's easy to measure things like that.
But this paper said we measured the process and it didn't change, and that's what I think is
process,
unlikely to be true. If you say, I'm only going to pay you if you give the person an aspirin, most of the time you will increase the use of aspirin.
Some of them are valuable. That one turns out to be valuable. Others are. ASAP gave 6 or 7 process measures, which we are part of the American payment system for Medicare, and it's like one of them is the oxygen assessment in pneumonia. Well, we know oxygen assessment in sprained ankles in our departments, so that was a no-brainer kind of thing. It was like they did all of these self-serving kind of little things, which may have really no effect on outcome whatsoever.
And some of them are bad. And it's very easy to imagine a paper performance which says you must give TPA for stroke, or you must give clopidogrel for heart disease. There are things that I would say, gee, they're wrong. But so there are real problems. The devil's in the detail. Who's going to write them? How free of conflict are they going to be? This is really important stuff. But it's not that they don't work. It's not that they won't influence us. They will. It just maybe not for the good.
For us anyway, we don't get paid for anything where I work. But the latest, we don't. But the latest push that I'm sure you're all seeing as well is this new "we won't pay you for complications, any patient with complications" thing, which has caused a huge uproar in administration, where ventilator-related pneumonias aren't getting paid for.
Hospital-acquired infections.
Hospital-acquired infections aren't getting paid for. So all of a sudden, these hand-washing things are popping up all over the place. How you're gowning and gloving to put in lines is becoming a huge,
not only that,
huge thing.
Culturing every person who went to the ICU, culturing them, that began first, right? Because if they acquire any kind of infection in the hospital, unless you can prove they had it when they came in, you're not going to get paid for it. Now, that was just the beginning. Now it is every admission. Every soul who gets admitted to our hospital will be cultured to determine whether they have anything before they come into the building. Just for this reason, so that you can say to the government, hey, they came in here with it, we didn't cause it, kind of thing.
Blood, skin, mucous membranes,
Or any wounds, any kind of decubiti.
That's the other thing. No, seriously, that's
Tap their joints.
The decube thing. Now we're actually, anybody that gets admitted everybody gets rolled, and if there's any even remote breakdown in the skin, it gets documented at admission. Because if a decube develops in the hospital, they don't pay for that patient's hospital admission.
Yeah, this is all horrible stuff, and it's all crazy. Even if they did develop it in your hospital, does that mean you did something wrong? Isn't that part of the things that happen? That happens. Even if you wash your hands from today till tomorrow, it's going to happen. Doesn't mean you did anything wrong. It's one thing to say you screwed up, you shouldn't be charging us for it. But what about these things happen? You didn't screw up. Something bad happened.
Cut off the wrong leg? Okay.
Diane, did I misunderstand you? If a person develops a DQ, they don't pay for the whole hospitalization?
Yes.
Regardless of what else was treated?
Yes. That's a CMS thing.
You get a single complication, they negate treatment for everything else?
Not all complications, but that one.
No, there's a list of 7 that they've come out with of things that happen in the hospital, one of which includes the development of a decubitus ulcer. They go, boom, we're done. It's just a way to not pay for things. It's another way to sort of curtail the budget. But
I hadn't heard about that.
Yeah.
What are the other 6, if you don't mind?
There's VRE. I've got the list.
As to whether or not they pay, and has that person even graduated high school? No, I'm serious. We have an art here, every one of us.
So you don't think this is a good idea, is what I'm hearing you say?
It's ridiculous.
It is ridiculous.
Weight of all the cultures on top of everything else.
Oh, yeah.
Right.
Taking swabs up people's butts to see if they have VRE when they come into the hospital.
I'm here for an ingrown toenail. What are you doing there?
It's horrible, and we should recognize that some of the motivation for this is terrible. Some of it is just a way to not pay you. But there is motivation for a lot of these things that where the initial idea was a good one. Gee, care given for the same disease in these 5 different hospitals is all over the map. And in fact, we know what the right answer is. We should say, look, everybody should do blah, blah, blah. That's a great idea. It's true. We should be responsible. If something is really well known, you should get aspirin, you should get aspirin. On the other hand, once you start doing that, there aren't that many things that are that well known. And for many things, it isn't for everybody. This guy should get the drug, but that guy shouldn't get the drug. But it's hard to write those types of guidelines. So now all of a sudden you start making these rules. And that's really, really dangerous. And then the unintended consequences of the rules, like how many extra infections are you going to create looking to prove they didn't have it before. There are all sorts of terrible unintended consequences besides just that it's inconvenient and costs money. And yet, once these things leave the station,
This whole country's out of control.
And I'm not going to take it.
Oh,
We weighted ourselves down
Yeah.
to allow this to happen.
absolutely.
That's because doctors have never been able to get together. There are 750,000 doctors in this country, basically a cottage industry that they can't even agree on the time of day. And as long as that occurs, basically you're going to be told what to do.
well, we laugh, but it's so we don't scream. We are in a absolute death spiral. And in the next 20 years...
Hey, you got to sit over there with that doctor.
when you look at the cost of healthcare in the next 20 years, we are so screwed, and we have done nothing to do anything about
And
it.
the boomers are coming.
So this is
It's a
different than the success we've had with the climate and the war and use of resources. I mean, otherwise we're in great shape. It's just,
There's a great BBC series that was just on, I think it was shown on PBS about the planet after we all freaking kill
love that.
ourselves. It's
The
going to be
2
so much better off when we're all out of here.
The roaches.
All right, you want to do number 6? You want to get back to anything clinical here?
no, I think we're
Yeah, I just want to go have a beer.
exactly.
Actually, I want to have 6 beers. Abstract 6 is about hypothermia. If you're dead and you don't wake up, then we should cool you down. It's an Israeli paper. It's more of the same stuff
We
from
like
Australia and other things. It's good. Mikey likes it. Cool them down. And I did it twice in the last month.
Ditto.
And how many of you do this? Not
In
very
Canada,
many.
all you do
You
is
just
open
stick
the
them
door.
outside.
Yeah, the ambulance door, the ER door. Minnesota is a good place for this too.
Yeah, they actually have to do warming.
You know-
They're already 28 degrees. We're going to get you up to 32.
Okay, next.
All right, number 7.
All right,
We got to the
number
paper
7.
you
All right,
wanted. There you go.
Canadians- The Canadians can gloat. Go ahead, gloat. Yeah, all right. We are not worthy. We are not worthy. Abstract number 7 says the United States sucks, basically, compared to Canada. And now we're done. No, what it basically looks at is it's a systematic review looking at healthcare outcomes. The United States spends basically, now it's, I think it's 17% of our gross domestic product on health. Canada is about 10%. U.S. rates 37th in the world as far as healthcare measures, under places like Botswana. And this looked at healthcare outcomes specifically, and basically found that Canada beats us by a mile. We're either the same on some things, but they're ahead of us on many as far as healthcare outcomes. It's not surprising. I mean, our healthcare system isn't a system. This is a healthcare system in Canada. We have a gazillion uninsured patients here. We have a lot of problems in the United States, and the bottom line is for as much money as we spend, we're not getting much bang for our buck.
You want
Everybody
to comment
says-
on that, Canadians?
Healthcare and health are different things, and our health outcomes in the States are very poor, and we spend zillions on healthcare. They're not the same thing. The reason our health outcomes are worse is not necessarily because our health care is worse, although in many ways it is worse. There are many other factors as well. But in every comparative study which has looked at advanced industrialized countries, the states always come out towards the bottom, if not at the bottom, and despite the fact that we spend more than anyone else. We also, if you think about it, when you average outcomes, you're not taking into account the fact that in the United States, there's much greater variation both in socioeconomic status and in availability of healthcare than there is in almost any of the other advanced countries where things are much closer. Everybody gets healthcare, and in the United States, a chief executive makes 550 times what a worker makes. In Japan, it's 25 times what a worker makes. It's very, very different in the way our societies are set up. And in the United States, we have 25% who get no insurance at all, and many people have very suboptimal insurance. So it's not surprising that our averages are not so good.
And that's why we go to Costa Rica for, you know, on the cover of your book there, we go to Costa Rica because Costa Rica, we're 37th according to the World Health Organization. Costa Rica is 36, and so we want to see what they're doing down there. Because we can move up one notch.
But don't worry, this is an election year, and the candidates have a plan.
They fixed it. Mm-hmm.
Let's
Yeah, go ahead.
So does that mean that for the people in America who do have access to care and who do have insurance, they must do much better in order to average
You'd think.
down?
Yeah, it actually doesn't. It doesn't quite mean that, although we shouldn't take it to mean that everybody does equally poorly. They don't. In the United States, some do better. But there's a great book that everybody should read by Shannon Brownlee called Overtreated, published last year. The New York Times called it the most important book of the year, and it talks about one of the problems that is undoubtedly true in our healthcare system is that we overdo things. And that overdoing, and the people who are the haves, who can get everything, who get screening tests, is that these cause harm. Overtreatment also causes harm. There's a tremendous amount of evidence of that. So undertreatment, no care is bad, but so is excessive care. And while you do much better if you're rich than if you're poor, you still don't do as well in the United States if you're rich as you do in England if you're rich.
Close the hospitals, wine, aspirin, and then you're done.
Chocolate. We have a few minutes left. Let's pick out any ones that you want to do in particular. Like number 9 says, it doesn't matter what vasopressor you use, if you use a vasopressor at all. We were told that dopamine's good for this, norepinephrine's good for that, and then when they went back and looked, we can't really find any difference picking why you ought to pick this one over that one.
Right, but I think the more important thing that they don't say is what you suggested, is that there is no evidence anywhere that vasopressors are good for anything. That's a bizarre statement, but it's true.
Pick out some others. I like 10. Which one do you want to... Oh, we'll get there. 10 is the nitrous by nurses. Nitrous by nurses. And the reason I put this in here is we're using no nitrous.
Personal use or for patients?
And the Australians, where are the Australians? Are they here today? There you go. You use nitrous 70% to take care of little painful things, and we're not allowed to use it. And here's U.S. nurses using it to catheterize kids.
Dental technicians can use it.
But
God forbid that doctors, emergency doctors, would abuse.
Now, doctor likes
50%.
number 17. We're going to get one. Anything before 17? 16. That's
16
right.
says don't have your heart attack on a weekend.
All right. Try to remember that.
You're more likely to die. Okay, 1%.
15 reminds us that there are really good regional anesthesia procedures for many painful injuries, and we should be familiar with them. I'm not so sure. Personally, I've tried this one a few times, and I'm not really sure it's that good, although I do think femoral nerve block is really good. This is a variation of femoral nerve block to stay away from the area where you're going to cause problems. I've tried it a few times, and I don't think it really works nearly as well as femoral nerve block. But the more important take-home point is that for a lot of the things we do, we could make things a lot better by using regional anesthesia for the acute part. And you give bupivacaine, you can make somebody pain-free for many hours.
Any others that you kind of are interested in?
17.
12.
Great important
Tap water's
paper.
good.
Tap water.
Tap water's good.
Not only is tap water not going to create harm, which it doesn't, but in addition, when we say irrigate, copiously irrigated, we're lying. Nobody sits there with a 50 cc syringe and does 2 liters of irrigation. It's impossible. The tap water takes 12 seconds to do it. So it turns out that every study has shown that tap water is at least as good and probably a little better in terms of wound infection than irrigation with normal saline. It's not because normal saline wouldn't work if you did it. It's impossible to do the same type of irrigation.
Could you apply that to the style of gloves with the regular gloves?
Oh, yeah, right.
There's papers on that as
the
well.
gloves are to protect you, it's not to protect them.
It's dirty.
And Judd Hollander's paper about head and neck lacerations, don't even clean them. Just spit in them and sew them up. They do fine.
So there goes the germ theory of disease right out the window. Pick another.
Gloves are probably important for certain things. They're not important for the simple laceration.
So the recommendation now is to use non-sterile gloves?
No, the recommendation is still...
Nobody's
We're too
never
wimpy to say that, but that's what the paper said.
I believe
Oh,
it's
yeah.
true.
What about the pressure
You got to turn the faucet on just right.
I love that pressure thing. You've got to get 50 pounds per square inch. I'm like, am I pushing 50? What have I got here? 30? What the hell am I doing?
Yeah, I mean,
I put a block in, and I'm sure you'll do the same. I just put a block, like arm lacerations. I put a block in so it doesn't hurt so much. I give them the little thing to wash it with and say, there's the sink, get busy. I'll be back in 20 minutes.
it's really, you know, there are a lot of things we should do because we can be doing something else while the patient feels something is being done. This is great. In the same way that it was proven many, many years ago that soaking a laceration is of absolutely no use, except it's really good to keep the patient thinking that they're busy.
No, it's when you go to lunch, you soak it. And you come back and say, it needs a little bit more
Not
soaking.
quite ready yet.
That's right. I'll be back in 20 minutes. Actually, increase the bacterial counts. Soaking increases the bacterial counts.
But then you wash it out at the sink.
You want to do it? Is that enough of this stuff? That's,
17, you promised him 17.
All right.
17 says alpha blockers are useful in preventing recurrences of kidney stones.
How many of you use the Flomax now? Everybody uses Flomax. The literature is compelling. The number needed to treat are 5 or 6. Kidney stones are painful. Why not do it? It costs $2 a tablet.
Yeah, no,
Yes.
it's recurrent revisit, not recurrence.
To facilitate the
Helps
passage,
pass it.
facilitate the
Yeah.
passage of this stone, Flomax.
Just 0.4 milligrams a day daily.
1 tablet a day, yes.
Oh, yeah.
Yes, and this is one of the things where people's practice changed like this when they became aware of it. There's no reason not to use it. There's no downside kind of thing. You might have an erection the last 4 or 5 days, but no problem other than that. Kind of thing, you know.
There's a downside or not, depending on your viewpoint of that.
So, no, this is...
That's the upside is what I heard you say.
So to speak.
Well, he does cynical to everything.
That's baseline.
I think it's perfectly reasonable to do it, but what I roll my eyes at when Rick says the evidence is compelling. The evidence is far from compelling, but
We have a
there is
disagreement.
very little in the way of a downside, so I think it's perfectly reasonable to do. This is not one I would fight about. It's supposedly for big stones.
It's supposedly for distal ureteral,
Distal ureter.
but
In
you know.
Italians, actually. They studied it mainly in Italy.
While they're having their heart attack, because they all have heart attacks too,
Right.
because they're all
On
in
their way to
easy.
thrombolysis.
No, basically, you don't know where the stone is, and you probably don't care, because it will get distal sometime, and when it gets distal, this stuff will kick in.
Yeah,
More important, send them out on NSAIDs. This is one of the very, very few places where NSAIDs really make a difference because it's prostaglandin mediated.
steroids haven't worked. Flushing it out with more fluids didn't work and actually increased their pain. Calcium channel blockers didn't work very well, but this one, in the 5 studies or so that have looked at this, it seems like it does, work. Give it a try.
No,
No.
absolutely not. Never
Toradol,
use Toradol.
I'll show you about
ibuprofen.
There's an NSAID study, there's an NSAID paper in here that talked about Toradol and renal failure in a couple of case
There is
reports.
no difference in efficacy in any NSAID. There is big differences in side effects,
What's that?
in anyone.
Even like that initial.
In anyone, they have equal efficacy. They have more side effects with some. The ones that's the least side effect is ibuprofen by far in every study. It's also the least expensive. You look at the list,
And
the
that's
ones
why
that have the most side effects, they're all the most expensive ones, including ketorolac.
There's a whole half hour on NSAIDs that are going to get covered here in terms of their adverse profile, renal, asthma, those kinds. There's a half hour here on that. Let's stop here because Diane has to talk about apology.